Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. This episode features content from an educational webinar titled COVID-19 Oral Antiviral Agents. During this podcast, Dr. Renslow Sherer, Director, International HIV Training Center and Professor of Medicine in the section of Infectious Diseases and Global Health in the Department of Medicine at the University of Chicago in Chicago, Illinois, discusses antiviral agents for non-hospitalized adults with mild to moderate COVID-19. For more information about Dr. Sherer and for a link to the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. Now, let's get started and hear what Dr. Sherer has to say about oral antiviral agents for COVID-19.
Thanks so much, Sarah. Thanks to everybody for joining today. I jumped at the chance to talk about some good news in the COVID field. I hope that you all are staying resilient and finding ways to maintain a hopeful approach. This is maybe one of the hardest eras that I think we've faced. So the subject today is antiviral therapy, and I'm going to talk about two, I think, very promising agents. PF07321332, I'm going to call it PF07 from Pfizer in combination with ritonavir as a booster, and molnupiravir from Merck in people who are not hospitalized with recent COVID infection. And the patient population here, importantly, is people who've recently been found to have SARS-CoV-2 infection, who are at risk for development of hospitalization and more severe disease and death. So have at least one or more comorbidity or just age over 50. And in this patient population, these drugs are the primary treatment for COVID-19. And we're going to look at efficacy data showing comparable efficacy to some of the early data for monoclonal antibodies. And probably most importantly, as you all know, with any antiviral, as in particular with oseltamivir and the treatment of influenza, the earlier that these drugs are started in the face of a viral infection, the better. And we're going to look at data where these drugs have been started within the first 5 days of therapy. So I'll start with PF07. This is a novel protease inhibitor, so the first in class of a protease inhibitor. You can see here in the figure sort of the insertion of this protease inhibitor into the protease molecule and the sites where it might bind and block the normal activity. It's a drug that's been shown to have activity against both alpha and beta coronaviruses. And those of you who are HIV clinicians will regard this as very familiar for the protease inhibitors. They have as a protein, very short pharmacologic life. The T half-life, as you can see, is only a number of hours. And that's extended dramatically with the use of the CYP3A4 inhibitor ritonavir. In this case, where you see 250 milligrams combined with ritonavir, 100 milligrams in a single dose, you get an extension of levels well above the EC90 for SARS-CoV-2 out to about 18 hours. And this drug is being tested, and I'll show you data with its use in a BID every 12-hour format. Those data are published. Also add is one of the contexts here, the difficulty of trying to assess these data in real time using both published studies, preprints, and then even press releases. And so it's sort of a caveat to all of the ways that we interpret these data to just appreciate that they're incomplete, that we all have an obligation to look at the full data set when it's finally available to us, just to review what we've seen in preprints and understood from abstracts or from press releases. So for PF07, this is the EPIC-HR study looked at in combination again with ritonavir. These are in non-hospitalized patients with at least one or more comorbidity or age over 50. And the original intent, and this is published in the National Trial Database, the intent was to enroll 3,000 individuals and to compare to placebo the use of this drug every 12 hours. So 2 tablets plus 1 tablet of ritonavir, 3 tablets twice a day. And the primary endpoints, which you'll see are consistent all the way through this presentation, was the percentage of patients hospitalized or dying by day 28. And the secondary endpoints were adverse events and safety. And so these are the interim day 28 results. Again, this was from a press release from the company. We haven't seen these full data, showing an 89% reduction in the risk of hospitalization or death with a highly significant p-value. And this is when started within 3 days of onset. And you can see that the data are actually quite similar. They stratified by either 3 days of within 3 days of onset or 5 days of onset. Really not significant differences between them, but the numbers are important. So for those who received the drug, hospitalization or death occurred, you can see in those who started by day 3, in 3 individuals, 6 individuals who started by day 5, in comparison to those treated with placebo, 27 by day 3 and 41 out of a total of 612 individuals who were started by day 5. And you can see also that by comparison, there were no deaths in the treatment group as compared to a total of 7 who were treated by day 3 and 10 who were started by day 5. So quite an impressive reduction in relative risk when started promptly within infection. I underscore that finding. The preliminary information on these 1,800 patients of safety analysis found very few serious adverse events in this 5-day therapy. You can see that overall drug discontinuations were actually fewer in the treatment arm in the range of 1 or 2% than they were in the placebo arm, which was 4 to 6%. And seeing these data, the DSMB stopped recruitment early. And I think in the absence of our full analysis of the data in a full publication that's been peer reviewed, it is reassuring to know that DSMB has reviewed these data and said these are powerful results for which we should stop this study. It's not ethical to continue. And an emergency use authorization request has been submitted to the FDA. So I think that's a very exciting potential new therapy. The one other thing I think I'd say about PF07, again, for those of you who are HIV clinicians, you'll recognize that the use of ritonavir and a CYP3A4 inhibitor that's quite powerful will have some drug interactions that will be important to anticipate. But that's clearly a strategy that I think that can be worked out that we've successfully managed in the HIV field. So let me turn then to the older of the novel oral antivirals, molnupiravir. You know that molnupiravir has been studied in a phase 1 study of 130 individuals, found to be well tolerated with a very good safety profile in the double-blind phase 2A study of another 202 patients who were randomized within 7 days of symptom onset. Some of the early trials showed a lower level of infectious virus isolation in 1 of 53 treated patients as compared to 16% or 9 of 54 who received the placebo. So a significant reduction in the ability to isolate SARS-CoV-2. And then among those who were seronegative at baseline, a shorter median time to clearance of the virus, 14 days compared to 27 days. So almost a halving of viral clearance. In the clinical trial registry, these trials are shown, the move in and move out, which are basically studies of molnupiravir in either hospitalized or non-hospitalized patients. In these extended phase 2 studies and phase 3 studies, they studied 200, 400, and 800 milligrams every 12 hours as compared to placebo with, again, the primary endpoint of a percentage of hospitalizations and or deaths by day 29 and safety. And so we'll look at the initial analysis. And there were 2 posters that were presented at Infectious Disease Week that addressed some of the early information from these studies. In one, an assessment of the activity of this drug against different variants was seen, against mu, alpha, and delta, and activity was retained. It was equal with each of those different viruses, which is important. We haven't seen the data yet in response in terms of Omicron, or at least that wasn't presented at Infectious Disease Week. And also there was a study looking at the novel mechanism of action. Molnupiravir is a mutagen. And so there was an analysis of the types of mutagenesis that occurred, the products that were identified as being created as a result of its normal action, And there wasn't a clear pattern of the development of a single mutagen, and there were not emergent resistance in that group. So two reassuring pieces of data that were presented at Infectious Disease Week. In terms of the phase 3 move out study, so this was the outpatient study, again, looking at individuals at risk of progression of disease and death, so either age over 50 or substantial comorbidity. And you can see in the original press release, this was on October 1st, looking at half of the patients, so about 385 people in the molnupiravir group, 377 in the placebo group. There was about 50% reduction in the risk of hospitalization or death to 7% compared to 14% for placebo. There were no deaths in the treatment arm as compared to 8 in the placebo arm. And you can see the safety profile was really quite good. And more recently in that analysis, it didn't seem to matter in terms of its efficacy, as I mentioned, against gamma, delta, and nu when that was extended. So that was followed up with a full analysis of all 709 patients in molnupiravir group and 699 in the placebo group. And the difference was still a significant benefit, but the difference fell to only a 30% efficacy. You can see that overall, it was 48 out of 709 who were hospitalized or died, as compared to 68 out of 699 in the placebo group, or 9.7. And what actually changed in those two data sets was the incidence of events in the placebo group. Otherwise, it was largely the same in the molnupiravir group, for reasons that are just not clear. You can see also that by the end of this analysis, there was 1 death in the molnupiravir group. There were 9 deaths in the placebo group. There was nothing new in this extended analysis in terms of the adverse event profile. And this was submitted for an emergency use authorization to the FDA. And it was approved by a vote of 13 to 10 with the judgment that the known benefits outweighed the risks. It's been authorized already now in the United Kingdom, and it's still under review with a decision that has yet to be made by the FDA and by the EMA. So just to make a comparison, I think, and this is across several different studies, you take it with a caveat, but in terms of the efficacy in preventing hospitalization and death, you can see in aggregate when we look at the efficacy for some of the monoclonal antibodies. So the Regeneron compounds, for example, sortrivimab and bamlanivimab and etesivimab, you can see that the overall reduction is a relative risk reduction in the rate of 71 to 85%, with an absolute risk reduction between 3 and 6%, where the proportion of folks who progress when they receive a monoclonal antibody is in the range of 1 to 1.3%, and those who are untreated in those trials was in the range of 4 to 7%. And that, again, is with symptom onset and treatment within the first 5 to 7 days. In comparison, the studies we've just looked at have seen a likelihood of progression to treatment between 1 and 6.8% in the treatment group, as compared to 6.7 to 9.7 in the placebo group. So a relative risk reduction of 30% with molnupiravir, or up to 85% with PFO7. So I would just underscore again that I think with all of these compounds, early recognition and treatment is really a critical priority within the first 5 days. And I think as we think about organizing logistically to try to respond to this and implement these, which has been challenging, I think, in most centers because of the need for an intravenous infusion with the monoclonal antibodies. There's now also the option with sortrivimab to use it as an intramuscular injection, and that's in study that has yet to be finalized, those data. And all of the studies to date have been done in patients who are not vaccinated. And so there's reason to think there might be variations in the benefits in vaccinated patients, but certainly still, I think they would be eligible for this intervention. And we've seen that costs and the administration, the logistics involved can be a real barrier. And I think the great potential benefit for the oral therapies is for simple diagnosis at the point of care in an emergency room, or referral to a center with a new positive test for confirmation, and then immediately giving an individual a prescription for an oral therapy for convalescing at home. So no need for admission and people can self-administer. And that's certainly the promise, I think, of these oral antivirals. So it's a pretty exciting moment. This is a time when we can really benefit from all the good news we can have. And I think the potential for oral antivirals that can reduce the potential for hospitalization and death is an exciting advance in the treatment of COVID. So let's turn then to the key points here. I think we've seen data that both molnupiravir and PFO3 and ritonavir offer a promising new treatment option for non-hospitalized adult patients with COVID-19. Clearly, these drugs work best when they're used early in the course of the infection. Much easier to integrate an oral agent, I think, compared to the requirements of an IV infusion or even an intramuscular injection. But we need as many tools in our toolbox as we can possibly have. And I think we've seen that the efficacy is comparable with the monoclonal antibodies in terms of the reduction of the risk of hospitalization and death. And I think scale up really will be a good bit simpler with these drugs. So with that, I'm going to turn this back over to Sarah, say thanks again to her and CCO for the opportunity to talk to you all, and happy to answer any questions and comments about these data or about COVID-19 therapy in general.
Wonderful. And thank you, Dr. Sherer, for that excellent presentation. As you may imagine, we've had a number of questions come in from participants, and we'll do our best in the time remaining to answer as many as we can. And so the first question that comes up is if you could comment on perhaps the comorbidities required of patients to be included in these clinical trials, and if we know what the average number or type of comorbidity was that gained someone that eligibility into the trial.
That has been published in the monoclonal antibody studies. And so you could get a pretty good sort of example of what we're likely to see. So older age has dominated. So it's been about 50% or more. And then you can sort of look at the prevalence across our population. What are the most common other comorbidities? So a large group have been diabetics, have been those with chronic heart disease and congestive heart failure post-MI. Maybe smaller numbers with cancer on chemotherapy, with a recent transplant and immune-compromised host, those who are HIV infected, and in particular, those with HIV who are untreated or who have advanced disease with T cells below 200. Those who are on chronic immunosuppressive therapies like long-term steroids or some of the other monoclonal antibodies for rheumatoid arthritis or for other conditions. Primary immunodeficiencies are much less common, but those folks would be eligible. We've had some other recent interesting additions to the list that might be a little more unexpected. So mental health and mood disorders, so depression falls on that list. Chronic substance abuse, because of the known higher mortality, lower likelihood of accessing health services, and other comorbidities that go along with it, and simple smoking. It's a remarkably large list. It's a very good question. Morbid obesity and morbid obesity also on that list, importantly. So I think it's a great question. I would be mindful of that list. CDC keeps thinking about additional factors that can lead to a greater risk of morbidity from COVID. So I urge clinicians on the call to sort of stay tuned to that list and be familiar with it. I think it's very helpful.
Great. And thank you for your thoughts on the comorbidity piece. We've had a number of questions come in asking about combination therapy. So I think it's sort of in two parts. Is there a role, or what is the role for using these oral antiviral agents in combination with one another? And then separate but related, is there a role, or what is the role in using oral antivirals in combination with monoclonal antibodies?
I think these are such important questions, and we're all struggling to keep pace with, I called it a tsunami of information, to keep track of just what's happened with the data in the most recent month or even shorter period of time. So, for example, just this week, we've seen some evidence in a laboratory analysis of the likelihood of some of the early monoclonal antibodies having efficacy against Omicron. And so etrivimab looks like it retains activity in one recent study out of Germany, and the Vir monoclonal antibodies did, but the others actually look as though their activity may be substantially less. And And I'm only saying that's a lab study. That's not the same as an efficacy study in people who are known to have Omicron. But Omicron is a wild card that I think is changing the equation on what's the likely efficacy of our current monoclonal antibodies and those in future. So it's important to stay tuned to that. Those of you with a background in HIV medicine, we believe firmly in combination antiviral therapy that's led to the extraordinary results of nearing HIV elimination. So in theory, it seems like a perfectly reasonable option. Only a clinical trial will answer that question thoroughly. It's a reasonable question to say, how much better can you get in terms of preventing hospitalization and death in people who are at risk for hospitalization than a reduction from 5% or 10% down to 1 or 2%. And remember that we'll be treating a number of individuals who otherwise are well or probably going to have only mild disease. We also don't know what the effect of these antiviral drugs in the short term will be with this very important emerging issue of long COVID. That's going to be a longer answer. It may well be that combination therapy is going to be a better answer than individual therapy. Time will tell. I would just urge that these wonderful clinical ideas, which I agree with, both. So I'm interested to know if either or both of those options will be successful, but I really want to know it in terms of a reasonable clinical trial that gives us the right answer and isn't just an ad hoc trial. We've gone down some blind alleys with ivermectin is one example, with some other COVID therapies based on a couple of anecdotes that seem to suggest that there are benefits. And so we have to be very careful of that. So I would say that was a long answer. The short answer is I do think that combination therapy may play a role, particularly combining the two antivirals that we have available. They have different mechanisms of action. I'm very impressed that we have at least the ability to reduce the chance of hospitalization or death by as much as 89% in the case of PFO7, if that pans out in subsequent clinical trials. And I think that idea of using it in combination with monoclonals is attractive. We've also seen growing data that there are additional uses for monoclonal antibodies for those patients who are already in hospital. We just saw that in the case of the Regeneron monoclonal antibodies, when used in patients who are already in the hospital in intensive care, it can reduce the likelihood of mortality for people who are ventilated. And that's the first time we've seen people with very far advanced disease seem to have responsiveness to monoclonal antibodies. So I don't think we're done exploring all the different ways where they might be of benefit. In this narrow patient population, I think it's also in terms of people who have mild illness, who are not sick enough to be hospitalized at the time they're diagnosed, but are at risk because of having comorbidities. There are also other agents like anti-inflammatories that have been shown to have an impact. Fluvoxamine, fluoxetine, which is Prozac. Surprisingly, the SSRIs have anti-inflammatory properties that also appear to mitigate or blunt some of the inflammatory responses with COVID-19 and to reduce the need for hospitalization. If that pans out, that may be yet another tool for oral therapy. And I think some of those trials are being set up now because those are drugs where we have a known safety profile and where they're already in widespread use. It's a long answer to a short question.
That's okay. Thanks for that answer. And, in answering that question, you answered a number of others, including we had a question about, fluvoxamine and maybe what its role will be. So thank you for your comments on that. I think this segues well into asking a question that came up about remdesivir. And we know that we have data using IV remdesivir in our non-hospitalized or outpatient population, and that it's being studied and reformulated as an oral agent. And just wondered if you could comment on remdesivir in this space for non-hospitalized patients.
This was another, I think, really important study that was presented at the IDSA annual meeting this year of the use of 3 sequential intravenous infusions of remdesivir in this same population we've been talking about, those who are outpatient, who have mild illness, have just been found to be infected, but are at risk for hospitalization and death because of a comorbidity or for their age. And in that population, a loading dose and then 2 subsequent days of doses, 3 days of IV therapy also was associated with a substantial reduction in the risk of hospitalization or death in the same range as we just talked about. And so I think that's quite an important observation. It's not very logistically practical, unfortunately, to have 3 IV infusions over 3 days. And that's the biggest barrier. So I think it's really welcome that they're looking into an oral formulation for the drug. And that would clearly make it a lot more feasible. And I regretted on seeing that trial that there hadn't been a group that had been studied with just a single infusion on that very first day, rather than only studying 3. And I think that would also be of interest. But clearly an oral formulation would be, I think, the best. And we're all heading in the same direction. What's simple, what's easy to implement, to scale up rapidly, that can reduce the burden on our hospital stays. And it looks like we really need this information urgently, these oral therapies as quickly as possible, because we have another wave clearly coming in the United States that'll be driven by Omicron. That's already happening in Europe, in the United Kingdom, in Denmark, in places that are actually very well covered with double vaccinations, and in some cases with boosters. And so clearly there's an urgent need for this. And I think while the companies, as I understand it, are scaling up rapidly to try to address the need, it will take some time. Molnupiravir is the furthest along to be widely available for use early in 2022. And PF07 will probably lag behind by a number of months. That's my best guess on this so far.
Great. Well, thank you again for your thoughts on that. Yes, it's very interesting to keep up with the evolving information and the waiting and seeing when we will have access to these medications. Going to molnupiravir specifically, we had a question come in asking if you could comment on molnupiravir and the risk of teratogenicity.
Well, I think that's the major reason for the 13-10 vote was not so much that the efficacy had declined from 50 to 30%. That was unexpected and still surprising. And I'd like to see the full data set to try to understand the difference in the first and the second group. Were there more younger people? Why was the placebo associated with a lower number of admissions? And there could be other reasons for that are unexplained. But in any event, I think the major hesitancy from some of the members of the panel was that mutagenicity is a little different than some of the other mechanisms of action that we've had, that some rapidly reproducing cells in people will be potentially susceptible. And so a very strong caveat was made that it not be used in pregnancy, and that women of reproductive age would need contraception in order to receive it. And I think that's a very important point for just being careful with that. There's not evidence in humans of teratogenicity, but in some animal studies, there has been an association that just raised that question that I think needs to be more completely studied. So it is something that's been looked at. It's why there's been, I think, some of the restricting the recommendations for the use of the drug in pregnant women and in women of childbearing age, to ensure that there's contraception on board. Nonetheless, to date, there has not been oncogenesis, development of new carcinomas, or other things that might be associated with that mechanism of action.
Great. Once again, thank you for your comments on that. That was an important point to comment on. I did have a question come in, I think related back to PF07 plus ritonavir, asking about how drug-drug interactions should be managed, such as warfarin interactions. With it being a relatively short course of medication, kind of what are your thoughts on how we would mitigate some of those big, well-known drug-drug interactions with ritonavir?
Sure, and I think that's a very important one, the warfarin question. Suspension of warfarin therapy during those 5 days is an option. Choosing alternative anticoagulation is an obvious other. A temporary alternative, I think, would be another option. And I think that'll be a case-by-case decision. We know of several other interactions that are extremely difficult with the rifampin and rifampicins, with the statins, although those are largely manageable depending on the statin. And So I think some reasonable accommodation for a 5-day window is something that most clinicians, I think, would say will address that in a temporary fashion in order to ensure that we can effectively prevent the likelihood of hospitalization or serious consequences. Another one that comes up frequently is cancer chemotherapy, and that would again be dependent on the individual chemotherapy. That would be a conversation with the oncologists for how best to manage that, to await the end of a sequence of chemotherapies if that's possible, or that'll be the challenge. And I think that comes back to the difficulty of making that choice where you have individuals who have a reasonable chance of actually not developing more severe COVID, not being hospitalized. So it'll be a case-by-case answer. So in some ways, we are making the clinician's job, I think, a little more complicated. Not a very satisfactory general answer, I'm afraid, but probably the best we can do. Over time, HIV clinicians using boosted protease inhibitors with ritonavir have come to understand sort of these interactions and have managed them successfully. So I would be reassuring about this in the vast majority of cases that there are workarounds and ways we can still administer this drug in a setting where it's needed and successfully manage the other drug-drug interaction.
Great. And thanks for your comments on that. It's definitely, not an easy thing to handle. And like you said, will be a case-by-case or individualized basis depending on the patient. I know that we talked in this webinar about the data for the oral antivirals coming out of our adult population and these agents being studied in adults. And we had a question about if there were pediatric data, what kind of pediatric data do we have available or maybe do we need, and how soon are we to have these agents authorized for a pediatric population?
Yeah, it always seems like pediatrics lags behind. I think here we have the sort of the additional impetus of a much less clinical severity with SARS-CoV-2 in children. I certainly would share with the questioner the interest in preventing any case of MIS-C that we could, if that were possible. But I honestly am not aware of, as of yet, of the clinical trials in development in children. I'm sure that this question is being asked at the company, but I don't have a concrete answer. In general, we've seen that adolescents, are biologically considerably more similar to adults. And so I would expect there to be the first uses to be offered in teenagers and young adults, and then clinical trials to be put into place. But it's a more difficult problem because, frankly, there's a much less severe disease in children and young adults. And thankfully, that's the case.
Thank you for your thoughts on that. Now, this is going to take us in a little bit of a tangent to this presentation, but wondering if you could talk to us about favipiravir, if I'm pronouncing that correctly, an oral antiviral that's been studied in hospitalized patients, and maybe what we know about that agent to date, and whether there's any interest or role for favipiravir, whether in hospitalized or non-hospitalized patients.
Yeah, that's a great question. Favipiravir had very positive, promising profile in vitro, seemed to have activity against it. And yet the clinical trials are disappointing. There was just a big study that was completed in Malaysia that's been put out into a preprint that studied 500 people, of whom half had SARS-CoV-2, pneumonia, and severe hypoxia. And they studied, it was initial dose 1,800 milligrams twice a day, and then 800 milligrams twice a day for the next 4 days, so a total 5-day course. And there was really no difference in any of the parameters that they assessed: likelihood of ICU, number of deaths, further disease progression. There's another drug also that Roche was developing with ATIA, the AT527, that had very good promise in vitro, which has not panned out in clinical trials. So they don't rise to our attention because they're good ideas that get tested and then don't seem to pan out in clinical trials. So far, I haven't seen any evidence supporting the use of favipiravir.
And I think we have time for one more question. The question is, would you use the PF07 drug in a patient with liver impairment? And are there any data on viral load reduction with this drug?
I have not seen virus load reduction to date with this drug. I think it's a really interesting and important question. It's been surprising that with remdesivir, we haven't been able to show declines in virus shedding or shorter times to virus shedding, where with some of the immunologically active agents, with the monoclonal antibodies, for example, we have seen shorter times of shedding. So in the case of the PF07, I haven't seen that data regarding shorter time to virus load shedding, but I think it is a critical question. And Sarah, there was a second part to your question. I'm sorry.
Yes, no, that's okay. The other question was, would you use the PF07 drug in a patient with liver impairment?
Yeah, we've seen, the question is, how bad is the liver impairment? And we've certainly have used, again, to use the HIV analogy, the boosted protease inhibitors, even in those patients with cirrhosis and end-stage liver disease. If it's decompensated, you can get into troubles with pharmacokinetics, but that would be the exception. In most patients, even those who have some degree of liver disease, these drugs can be safely used. And then, of course, it's a case-by-case answer with the degree of the severity and what other issues that patient has. But in general, that would not discourage my thinking about its use. And people with severe liver disease are in that group who are immune compromised relatively. And so certainly deserving of, they have comorbidities that put them at risk for hospitalization or death from SARS-CoV-2. So it's an important group to include in those eligible for both molnupiravir or PF07.
Thank you very much to Dr. Sherer, and thank you to our listeners for joining in. As a reminder, to view the full COVID-19 Resource Center on the Clinical Care Options website, click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.